Hi, my name is Chevy and I'm a genetic counselor here at Catholic Health. Today I'm going to give you a little bit more information about hereditary thoracic aortic aneurysms and dissections and why you might want to speak to a genetic counselor regarding your own aneurysm or dissection or family history of one. Specifically, we're talking about thoracic aortic aneurysms and dissections. Thoracic aortic aneurysms and dissections are fairly common in the general population, but unlike other types of aneurysms, around 20% of these are familial, meaning around 20% of people who have a thoracic aortic aneurysm have a relative who also has one. We are specifically talking about the thoracic aorta, which is the part of the aorta that is above the diaphragm, often the ascending aorta, which is the part of the aorta that is directly leaving the heart. As you can see in the image on the right, blood is going from the left ventricle in the heart up into the aorta, and that first beginning part is called the ascending aorta. It then turns into the aortic arch and goes down in the descending aorta. Aneurysms can happen in any artery in the body, but when we are talking about these hereditary ones, we are most concerned about ones in the thoracic aorta rather than abdominal aortic aneurysms or brain aneurysms, which are less likely to be genetic. An aneurysm occurs when the wall of the aorta gets thin and stretched out, kind of like a rubber band or a ponytail that's been used a few too many times. It is still intact, it appears larger on imaging, and we are concerned that it might rupture at some point. A dissection is when there is a tear within the wall of the artery, and so blood is not only pumping through where it's supposed to, it is also pumping into that opening within the wall. Aortic aneurysms and dissections can result from chronic high blood pressure, from stress, from increased blood volume, or from narrowing, but they may also arise because maybe the aorta is not built to the strength that it needs to be, and this can be genetic. Additionally, some people are born with a bicuspid aortic valve, which is one of the most common congenital heart defects. It affects around 1 to 2% of the general population, and around 50% of people who have a bicuspid aortic valve go on to develop a thoracic aortic aneurysm. They also have a high risk of aortic dissection. These often run in families with autosomal dominant inheritance, which means that if one person in the family has it, their closest relatives have around a 50% risk to have one as well. We're all made up of millions of cells, and in each of our cells we're supposed to have 46 chromosomes that are made of DNA. Little sections of DNA are called genes, and every gene gives the body instructions on how to perform a specific function. The genes that we're thinking about today are genes that are involved in giving instructions on how to build the aorta and our other blood vessels. Many of these are called connective tissue genes. Of the genes that are related to aortic aneurysm, some of these are syndromic, which means they may cause symptoms outside of the aorta, and some of these are non-syndromic, which means a person may have no other symptoms from this gene not functioning correctly and may only have the aneurysm or dissection. When we do genetic testing, we are able to look at all of these genes at once with one single test. Some of the other symptoms that we see with aortic aneurysms and dissections when they are genetic include ectopia lentis, detached retina, glaucoma, and cataracts. With Marfan Syndrome, with Marfan and Loeys-Dietz syndrome, we'll see some skeletal features including scoliosis, pectus excavatum and carinatum, which is a unique shape to the chest, as well as joint laxity. Individuals with Loeys-Dietz syndrome and Ehlers-Danlos may have soft velvety skin. They may bruise easily and scar easily. Some craniofacial features with Loeys-Dietz include cleft palate and craniosynostosis. There are also many other symptoms that I have not listed here, but you would go over with me or your genetic counselor if you met with us. Ehlers-Danlos Syndrome is one of the conditions that we test for when we do genetic testing for aortic aneurysms and dissections. There are 13 different types of Ehlers-Danlos Syndrome, and they primarily have to do with genes related to collagen. Collectively, they affect at least 1 in 5,000 people, but some types of Ehlers-Danlos are more common than others. When we're thinking about aortic aneurysms and dissections, the type of Ehlers-Danlos that we are most concerned about is specifically type 4 or vascular Ehlers-Danlos syndrome, as this disease has a high risk of dissection. The other types of Ehlers-Danlos syndrome may also have risks of aneurysm and dissection as well. We also test for Marfan Syndrome, which is a condition that is most known for its three primary features: the eyes, the bones, and the heart. Around 60% of individuals with Marfan Syndrome have ectopia lentis, which is a detached lens, and at the very minimum, they usually have nearsightedness. Individuals with Marfan Syndrome typically have bone overgrowth. Their arms and their legs are disproportionately long for the size of their torso. This results in them often being several inches taller than their other family members. Of course, our biggest concern with individuals with Marfan Syndrome are the cardiovascular symptoms. They often have dilatation of the aorta, mitral valve prolapse, and enlargement of the proximal pulmonary artery. It is important that individuals with Marfan Syndrome see their cardiologist and their cardiovascular surgeon regularly, and we are able to test for Marfan Syndrome. It is one of our big concerns when we do genetic testing in individuals with aneurysms and dissections. There are some other features as well with Marfan Syndrome, including some facial features, as well as dural and hernias, stretch marks in the skin, as well as a risk of spontaneous pneumothorax or lung collapse. It's important to keep in mind that even if you think you might have the symptoms of Marfan Syndrome, that doesn't mean you have to have a family member with it. Around 25% of the time, this is new in an individual, and they actually have not inherited it from a parent. Additionally, not everyone with Marfan Syndrome will have all of these symptoms. We sometimes see somebody who has only one of these symptoms or very mild versions of these symptoms. Most of the diseases that we test for, including Marfan Syndrome, have autosomal dominant inheritance, which means that of our 2 copies of each gene, if one isn't working, that is enough to give the person the disease. This means that for every child they have, there is a 50% risk that that child will inherit that disease. If it is inherited from one of their parents, then their siblings would have a risk of having this disease as well. And so we do recommend testing family members after a person is test positive for a dominant disease. We do test for some recessive diseases as well. With autosomal recessive diseases, a person needs to have both copies of a gene not functioning correctly in order to have any symptoms. We do occasionally have patients test positive as being carriers of genetic diseases relating to aneurysms and dissections. When that occurs, then it means that even though they have a gene not working right, it likely has nothing to do with their aneurysm. But if their partner is also a carrier of the same disease, they would have a risk of having a child with that disease. When we do genetic testing, we get 3 different types of results. Positive result is when we have found that a gene is not functioning correctly, it has a pathogenic variant or mutation in it, and it is not giving proper instructions. What results is that your medical management would change based on these results. You might be recommended to have an aneurysm repaired early or go for additional screening that you were not going for before. Additionally, we would want to test your family members to make sure that if any of them had the same mutation as you, they could get treated appropriately. Negative result is when we don't find anything, and this happens more often than you'd think. With a negative result, this could mean that your symptoms are not sporadic, your aneurysm just happened randomly to you and had nothing to do with genetics. But because we know that thoracic aortic aneurysm and dissection are so familial, we would still want your family members to get screened regularly, just in case there's something genetic that we couldn't find. We do also get variants of uncertain significance, which are inconclusive findings. When we get these, then it means that the lab found something that's different in one of your genes. Different does not mean bad. It just means that we cannot interpret it at this time. Whenever we do genetic testing, it is important to keep in mind the Genetic Information Non-Discrimination Act. This is a law that protects individuals from genetic discrimination regarding medical insurance and employment. There are some exceptions. The biggest exceptions that we are concerned about are for life insurance, long-term care insurance, and disability insurance. And so if a person is applying for a new life insurance policy or trying to upgrade a current policy, they are allowed to discriminate based on genetic test results. Thank you for your time.